Welcome to 2-Minute Anaesthesia in Critical Care. Today we're going to look at the ABCDE assessment, which is a structured, rapid approach to managing critically unwell patients. Whether this is in ICU, the emergency department, it's important to have a structured, fast approach. Let's get started. So why do we perform an ABCD assessment? It's to quickly identify and treat life-threatening conditions in order of priority. This structured approach ensures no step is missed, allowing a rapid assessment, stabilisation, facilitation and communication between staff in time-critical situations. The basic assessment involves airway and cervical spine mobilisation, breathing, circulation, disability and exposure, but this can be extended to additional factors. These additional factors include fluid, gastrointestinal, hematological, infection and line assessments. It's important to remember before you perform an ABCD assessment, stop and look. Observe the patient. Is the patient well, chatting, sitting there on their phone, or are they critically unwell with a lost airway, low conscious level? Is anyone available to provide a brief history in order to provide a dedicated specialised ABCD assessment? Now let's discuss the ABCD assessment. So firstly, airway assessment and cervical spine mobilisation have indicated. Airway assessment. Is the airway patent? This will enable gas exchange, oxygen entrainment and carbon dioxide removal. So signs of airway compromise are broad, but a look, listen, feel approach is essential. Look, is there any visible signs of obstruction, vomit, foreign body which could be cleared immediately? Is there any additional noises? Is the patient speaking normally or is the airway compromised? The noises could be stridor, gurgling or snoring. The level of the compromise may produce a specific sound. You could also feel the airway in regards to the airway breath sounds from your hand on your cheek and also palpate the trachea. If indicated, cervical spine mobilisation may be important based on the history. And then from this assessment, it's important to provide an intervention if indicated, i.e. a non-rebreathe mask, an airway adjunct, additional airway support with a Mapleson circuit, but also, if indicated, plan for intubation. Breathing. What is the respiratory rate and the saturations? Observe the breathing pattern. If appropriate, expose the patient's chest to observe the increased work of breathing if present. Look for accessory muscle use, nasal flaring, cyanosis. Inspect the chest for signs of injuries, wounds and deformities. Palpate the chest. Auscultate the chest. Is there additional sounds, wheeze, crackles, absent breath sounds? Look for example, a silent chest and asthma. Do any specific interventions need to be performed, i.e. for attention pneumothorax? Perform an ABG, get a chest x-ray, and from this there may be an escalation of care to NIV or CPAP. Cardiovascular. Check the heart rate, blood pressure, observe the patient, look for the colour, assess the peripheral central capillary refill time, normal is less than 2 seconds, observe the JVP, auscultate the heart sounds, assess the lower limbs, insert a cannula if indicated, small bore versus large bore, take a full set of bloods including a group and SAB. Does the patient need fluids? Recheck the gas, look for base excess and lactate. What is the clinical picture? Does it suggest shock? Does it suggest tamponade or ongoing bleeding which needs immediate management? Disability, the triad, either GCS or AVPU, followed by pupils and BM. Is the GCS low? What is the cause of this? Is it drugs, cranial hypoglycemia? Is there any specific treatments which are indicated at this current point in time? Exposure. If clinically indicated, expose the patient looking for hidden injuries, rashes, bleeding or signs of infection. Check the temperature and look for pressure areas but also medical devices. Maintain the patient dignity and prevent heat loss. Fluid assessment is an additional assessment as part of the cardiovascular assessment, but it's important to be thought of separately. If the patient is on the ward, they could have an input-output chart, enabling assessment of the volume status. What is your clinical assessment of the volume status during the cardiovascular assessment? Are they overloaded, hypervolemic, hypovolemic, normovolemic, or have they got extensive third spacing causing edema? Does the patient need diuresis of fluid? If overloaded, diuresis may help the cardiorespiratory interaction. Gastrointestinal. Look at the abdomen. Is there any bruises? What is the colour? What is the volume? Palpate. Assess for organomegaly. Auscultate for bowel sounds. Does the patient need gastric decompression via a gastric tube? Hematological. This is another extension from the cardiovascular assessment, but it's important to think of it individually. Is the patient bleeding? Are they hypovolemic? Do they need additional blood products? What is the clotting risk? Do they need anticoagulation, clotting factors, or additional blood products? Infection. Are there any signs or suspicion of infection? Is there any clinical evidence in the form of fever, biochemical in forms of white cells, CRP or PCT? Is there any new or old microbiology evidence on the system? Is there any risk factors? Is the patient IVDU, care home resident, recently discharged? And therefore, does the patient need any treatment or prophylactic antimicrobial agents? And finally, look at the patient's lines. These could be gastric tubes, venous and arterial cannulas, catheters or drains. How old are these lines? Are there infection risk? Does the patient need escalation of these lines, for example, a cannula, escalate to a central line to optimise delivery of fluids? And finally, reassessment. This is essential to reassess the patient, to assess if the patient is improving or deteriorating and understand their trajectory. Once again, thank you for watching.